Good evening, students and colleagues who are attending this talk on typical and atypical Alzheimer's disease. Uh, July 22nd is World Brain Day, and yesterday we couldn't conduct because there are Dr. Meshram's program, and because the concept of this year is multiple sclerosis. So we thought that we'll do it on next day, and the brain function is studied here. Typical and atypical Alzheimer's disease, when the dysfunction sets in older age groups or younger age groups. That's going to be the talk of this evening, and we'll have an interactive session. I wish people will interact. Unfortunately, this World Brain Day is marred by the virus, and we have been suffering the last 1.5 years with the pandemic. The whole curriculum has gone topsy-turvy. Still, we'll try and keep up with our academic pursuits. So let's understand the dementia syndrome first, and one or two slides on what's a dementia syndrome and how you define it. Is there any uniform definition of the dementia syndrome? The objective cognitive or behavioral impairment in at least two of the following. This is the NIA definition, and so there are about 6 or 7 definitions, and what definition which this is used for this talk is this definition. I'll tell the significance of these other definitions. So at least two of the following should be there: memory, reasoning, and handling complex tasks. Some problem there. Visuospatial abilities. There should be some problem in language functions, personality, behavior, comportment, and functional impairment, that is decline from the previous level of functioning. So the problem with dementia syndrome is it's defined by various criteria. The latest being DSM-5 criteria, ICD-10, CAMDEX, ICD-9, DSM-4, DSM-3 or DSM-3. If you take 100 patients whom the clinicians suspect have dementia, ICD will diagnose only 3%, CAMDEX 4.9, DSM-4 13%, DSM-3 29%. So the diagnosis of dementia itself is not standardized, and the definitions used by various studies are different. So that what I said, we are going to use this definition for this talk. So the presenting symptoms when dementia comes will be memory defects, and what people really say is he's going on repeating himself or herself. He rapidly forgets conversations, and he can't do multitasking. He's got poor judgment. He can't plan. He can't work sequentially. He forgets words, word finding difficulties, talks around missing words, mispronounces common words, don't understand him or other, so maybe having visual symptoms, blurry vision, can't align things, problems with seeing and reading. So these are various domains that can get affected: visuospatial, language, executive function, and anterograde memory loss. So these are the various domains that are usually tested, and you can see them: the frontal lobe and the hemisphere, right cerebral hemisphere, which has got a topography, visuoconstructive disorders, hemispatial neglects, prosopagnosia. Now the left side dominant hemisphere has got aphasia, agraphia, alexia, apraxia, acalculia, finger nose, finger agnosia, and the pure alexia. Now all these things, these are the things, domains which are usually affected in the dementia syndrome. So first question to us is, in what brain region do amyloid beta plaques first appear in patients with Alzheimer's disease dementia? So primary degenerative dementias are three mainly: Alzheimer's dementia, frontotemporal dementia, diffuse Lewy body dementia. These are the three primary degenerative dementias which we should know. And if anybody wants to volunteer to this answer, what brain region do amyloid beta plaques first appear in patients with Alzheimer's dementia? Is it in diencephalon? Is it in the hippocampus, in the limbic structures? Is it neocortex? Is it striatum? Anybody can answer? Since being it's an interactive, it will be nice if somebody can answer. Otherwise, I'll go on to the answer myself. And so, the main pathology of Alzheimer's disease is the senile plaques and neurofibrillary tangles. So we'll read a bit more about this. The neuropathological features of AD dementia include senile plaques and neurofibrillary tangles. The senile plaques are deposits of aggregated amyloid beta polypeptides, and which with the pathway is very important. And new drugs have developed in that pathway. Amyloid beta plaques first accumulate in the neocortex and followed sequentially by spread into the hippocampus, the limbic structures, and striatum. So this is an important aspect to remember. And diencephalon, brainstem, and cerebellum. In fact, the amyloid deposition starts much earlier than the clinical presentation, and that's the recent developments say that the pre-diagnosis of uh, Alzheimer's disease well before the clinical thing is possible nowadays with amyloid PET and tau PET. So the AD pathology of plaques which are seen here, the plaques and the tangles are seen, the plaques are here, the tangles are here, and the cell death and gliotic areas are seen here. So these are the important pathological findings, and the staging has been developed depending on the accumulation of amyloid beta, amyloid plaques, and this staging is important for the students to know about the staging. They have to go back to the staging, and this is the Brock stage of neurofibrillary tangles, amyloid beta, phase 1, phase 2, phase 3. It starts development of the accumulation of amyloid beta starts from the brain stem, and as by the time the clinical manifestations have appeared, the individual is already accumulated so much of amyloid beta in various regions of the brain. So these are the neuritic amyloid plaques and neurofibrillary tangles, which are the characteristic of the AD pathology. And the pattern which I said is early brainstem involvement. That's a correction. It started much earlier in the clinical before the clinical manifestations have appeared, at least 10 to 15 years before the accumulation starts, and which will destroy these neurons. So which of the following APOE genotypes is most protective against late onset Alzheimer's disease? Now, Alzheimer's disease has got a genetic connection, and it can be autosomal dominant, autosomal recessive. So one of these genotypes is most protective against late onset Alzheimer's disease. Late onset is above 65 years. The young onset is below 65 years. Which of the following APOE genotypes is most protective? You all know that APOE, apolipoprotein E, predisposes to Alzheimer's dementia. That's a thing which we know. That chat one, yeah, that's correct. Yeah, Danish Katuria, that's correct, and we'll learn a bit about this genetics of Alzheimer's disease. It's just because this is a World Brain Day, we are trying to study the brain function. Autosomal dominant, chromosome 21, amyloid precursor protein, presenilin 1 and 14, presenilin 2 and chromosome 1. So the chromosome 19 apolipoprotein E, this is got a low penetrant semi-dominant one. There are other mild risk factors. So whenever this combination of E3 by 4, there is elevated risk. E4 by 4, it will elevated risk is there. So this risk is less with the A answer, that the what is amyloid, this autosomal dominant proteins are the genes APP, presenilin 1, presenilin 2. All these three genes affect brain amyloid, leading to the amyloid hypothesis that amyloid accumulation is the main cause of the Alzheimer's disease. And this pathway, which has got various enzymes, alpha secretase, beta secretase, and gamma secretase, the various modalities of treatments have been tried. Unfortunately, none of them is successful. The answer is the apolipoprotein 2. The strongest genetic risk factor we all know is the apolipoprotein E genotype. However, apolipoprotein ECO2, which is found in approximately 8% of the population, is associated with a reduced risk of developing AD. The odds ratio approximately 0.5 among the homozygotes compared to the more common alleles of 3 and 4, which increase the risk odds ratio of 8 to 12 among the homozygotes. So Apolipoprotein E, well, let's study a bit what is that apolipoprotein E, why, where is it present in the body. It is produced in different organs, including the brain. It's a part of the cholesterol shuttle pathway. There are three common versions of alleles are available. The E4 increases risk by 400% in heterozygotes and by 1200% in homozygotes. E2 is protective. That's what we read just now. It reduces but does not eliminate the risk. The absolute lifetime risk of an E4 heterozygote roughly 29%, E4 homozygote roughly 60%. Of course, it depends on multiple factors also, but there is a practice parameter, but does not recommend that we should do ApoE testing. It's only knowledge we have to study. Okay, that's the second question. We will keep on discussing more questions. Now we'll just go here and there. We'll see the acetylcholine receptor, in the acetylcholine esterase inhibitor. They should be used with caution in patients with Alzheimer's disease, because we all start with donepezil, rivastigmine, dermatol, the galantamine, and all these medicines, memantine. Memantine is used by people in mild, moderate, and severe, wherever they like, they keep using, who have a history of which are the following comorbidities which the inhibitor should be used with caution. Is it bradycardia, constipation, depression, glaucoma, and hypertension? So all the residents and DNP neurology residents, every resident uses them. The moment diagnosis by psychiatric people, they cut loose on using acetylcholine. So we should know a bit. We should be having that side effect in our mind. Anybody can answer this. Is it bradycardia? Is it constipation? Is it depression? Is it glaucoma? Is it hypertension? Which history will make us very cautious to use this drug, acetylcholine esterase inhibitors? And we have to do more questions, so I will change the gears and go back to this. So bradycardia, if the individual is bradycardia, their mainstay of yeah, did somebody answered? I think that's nice. Yeah, that's good. Right, only Danish is the acetylcholine inhibitors are the mainstay of pharmacological treatment for Alzheimer's disease. Although benefits are modest, the difficult to appreciate in clinical practice. The side effects reflect actions on parasympathetic nervous system, with the most common one reflecting the GI hypermotility, diarrhea, nausea, vomiting, anorexia. The medications also may cause bradycardia, hypotension, bronchoconstriction, and decreased intraocular pressure. So one has to be careful in that sphere. The major neurotransmitters which are in Alzheimer's disease are acetylcholine. The systems that are affected: acetylcholine, serotonin, norepinephrine, dopamine, melatonin. All these neurotransmitter systems are affected in, or they in Alzheimer's disease. If you look at the cholinergic pathology, it's early, selective, severe neurofibrillary damage which occurs in nucleus basalis of Maynard. In 80% loss is seen in that. Uh, its reduction in muscarinic and nicotinic receptors. It impaired synaptic physiology. And what is the clinical impact of this deficiency? It's alteration of modulatory activity throughout the cortex. It impairs cognition, memory, set switching, attention, naming, and these are the defects, because cholinergic projections of nucleus basalis, which are depicted here, are extensively distributed in the brain. The treatment with cholinergic treatment is effective, and like modest symptom reduction, behavioral benefits, depression, anxiety, apathy. So you can see the drug is placebo controlled trial, and all active treatments, the scale is better than the placebo. So there is slight improvement, but we have to keep the side effect profile in mind. Fourth question: 85-year-old man with Alzheimer's disease who is being treated with donepezil and memantine is experiencing anxiety, anger, and aggressive behavior. If non-pharmacological interventions are unsuccessful, which are the following pharmacological treatments represents first-line therapy for his behavioral symptoms? Atypical neuroleptic, benzodiazepine; conventional neuroleptic, selective reuptake inhibitors; and tricyclic antidepressants. So which is the important one, that is the which one? we should use and why. We have already seen the pathways that are affected, so you can easily guess in this. A person who's got anxiety, anger, aggressive behavior, if non-pharmacological interventions are unsuccessful, which of the following pharmacological treatments represent the first line therapy for behavioral symptoms? Can I have an answer? Somebody can answer? Can, or let's see if you can guess. No chart is coming up. So shall I show the real? Right. So non-pharmacological intervention should always be attempted for behavioral symptoms in AD, since they are most effective than pharmacological interventions and are not associated with significant morbidity and mortality that can be seen with pharmacological therapy. If pharmacological therapy is deemed necessary, the first line agent includes SSRIs and serotonin norepinephrine reuptake inhibitor SNRIs. Benzodiazepines should be avoided because of the sedative effects and the potential to worsen the cognition, and they also cause delirium and incoherence. Tricyclic antidepressants should be avoided because of their anticholinergic properties. Neuroleptics, both conventional and atypical, should also be avoided if possible because of evidence of increased morbidity and mortality in patients with dementia. So what we are left with is SNRIs and SSRIs. And so the serotonergic pathway, there is a denervation which is reflected in the control. You can see the MCI and AD. The pathway, there is denervation in neocortex and hippocampus. There is a decline in 5-HT levels throughout, especially in young. There is a loss of 5-HT1, 5-HT2 receptors, and so there is, as a result, the clinical impact what we see is a sleep-wake disruption. There's a decreased temporal 5-HT1 binding, and so there will be more disturbances, cognitive decline, and cognitive dysfunction. All these things can be uh, treated by, you can see the raphe nuclei which are responsible for the serotonin secretion. So reuptake inhibitors will help in preservation of cognition to some extent, and behavioral improvement also is there. In the broad meta-analysis, it's shown that this better. There may be they are useful 5-HT1 antagonists. They, though weak in the evidence, they are useful in agitation and aggression and other behavioral problems. So the point to learn is that serotonergic treatment is beneficial. So let's read a bit about Alzheimer's disease before we go to the atypical ones. After excluding the reversible causes, the commonest cause of late onset dementia is late onset Alzheimer's disease. Now, Alzheimer's disease, the reversible causes comprise about 10% of all the dementias, but the major cause is Alzheimer's disease, and Alzheimer's disease is typically presents with progressive decline in episodic memory, with variable involvement of other cognitive domains in more than 65 age group. The common neuropsychiatric symptoms: depression, anxiety, apathy, irritability, sleep disturbances. Progressive memory impairment can also be caused by other disorders affecting the medial temporal lobe. But the characteristic of Alzheimer's disease is episodic memory impairment. Now, how you define that is, there is a anterograde learning defect. Now, anterograde learning defect you have to identify by a race auditory verbal learning test or a paired associate learning test. There are other tests where you try and make them do these tests, and the estimated heritability is 60 to 80% of this. The primary genetic risk factor we have already read is apolipoprotein E, E4 allele. Risk factors are vascular factors, sleep disturbances, traumatic brain injury. There are some protective factors, that is the cognitive reserve, that is the cognitive reserve with increased years of education and greater cognitive and physical activity throughout the lifespan. Mild cognitive impairment, first normal individual, then MCI, then amnesic MCI, then AD. We can define the MCI as objectively confirmed cognitive decline that does not interfere with independent function. When cognitive decline interferes with independent function, patients meets the criteria for dementia of Alzheimer type. Though medial temporal lobe and posterior predominant cortical atrophy is characteristic finding on neuroimaging, at times on the gradient echo sequence there will be microbleeds associated with cerebral amyloid angiopathy. As we said, the neuropathologies, late life dementia is often associated with multiple brain pathologies. The most common pathologies are Alzheimer's disease, Lewy bodies, vascular brain injury, hippocampal sclerosis, and TDP43 inclusions. The burden and distribution of amyloid plaques and tau and neurofibrillary tangles define the degree of Alzheimer's disease neuropathology changes. In vivo, CSF levels of amyloid beta and phosphorylated tau help us. Is a biomarker, important biomarker. Low amyloid beta and raised phosphorylated tau is a characteristic CSF finding. PET scan with radio tracers that selectively bind amyloid beta or tau. These are also important biomarkers. So that's Alzheimer's disease thing. Then we are going to see about the treatment. The treatment is mild and moderate, are treated with donepezil and rivastigmine. That is only the symptomatic treatment. The severe, moderate to severe are treated with memantine. The behavioral abnormalities, as I said, already treated with and SSRIs and SNRIs. These are important ones. Donepezil start with 5 milligrams and gradually increase to 10 milligrams. Rivastigmine, we can use a skin patch with 5 grams, 5 milligrams, and 20 milligrams. There are large patches also available. So that will improve the temporarily the cognition for some time. So the clinical features: progressive cognitive decline beginning with memory impairment. The learning and memory are more important. And as in, I have one more talk on frontotemporal dementia in my neuro Pathsala, where you can see that memory is not affected in frontotemporal dementia, but this is a major impairment in AD. The language functions, the executive functions, and visuospatial functions, they are also involved, but to lesser. This is the profile of AD. And typical Alzheimer's neuroradiology, the normal cognition, and the MCI, that is showing some atrophy of the brain and dementia at 86. So 75, 81, and 86. They progressively lose MMSE points, yearly 1 or 2 points, and gradually they become more significant, and they can be detected by FDG PET. You can see the mild early, right lateral, left lateral, and right medial and left medial. The posterior part and the temporal lobes are affected mostly in these severe and late phases. This amyloid and tau PET, you can see the abnormalities which are detected. The question 5: which of the following is the most common cause of neurodegenerative dementia with onset before the age of 65 years? Autoimmune encephalitis, cerebrovascular disease, early onset Alzheimer's disease, frontotemporal dementia, Lewy body dementia. Which of the following the most common cause of neurodegenerative dementia with onset before 65 years? More than 65 years is late onset Alzheimer's disease. But what is the most common thing? Anybody can answer this? See, we have to do
See, we
it.
have to do it.
So anything,
So
any,
anything, any,
Frontotemporal dementia.
no, it's not.
no, it's not.
So the one that is or D. Okay. It is early onset Alzheimer's disease, the most common cause of neurodegenerative dementia with onset before the age of 65 years, and accounts for at least one third of early onset of dementia cases. Other cases include vascular disease, frontotemporal dementia, drug related conditions, Lewy body disease, and autoimmune and infectious conditions. The importance of knowing early onset Alzheimer's disease is because we are increasingly diagnosing these early onset, which are atypical variants. The manifestations and the presentations will be discussed in future slides. So, which of the following is the more characteristic of early onset Alzheimer's disease than that of late onset Alzheimer's disease? Higher rate of antecedent traumatic brain injury, higher rate of diabetes mellitus, lower age controlled mortality rate, lower genetic predisposition, shorter duration of disease before diagnosis. What is the characteristic feature of early onset Alzheimer's disease? That's why the importance of this talk is to identify early onset Alzheimer's disease. As I said, the late onset is characterized by problem of episodic memory, that is higher rate of diabetes mellitus. That's what you want to say. Okay, let me see. Shorter duration of disease before diagnosis. Okay, let me see. That's not the answer. It's the traumatic brain injury. That's the most characteristic thing. See, the patients with early onset disease AD are more likely to have a history of traumatic brain injury as a risk factor for dementia than those with late onset AD. Early onset AD is associated with a higher rate of genetic etiology and a higher mortality rate than the late onset. Although patients with early onset AD have on an average more aggressive clinical course than those with late onset, patients with early onset have a longer duration of disease before diagnosis. This is because they are missed, diagnosis missed or delayed, or a greater extent of evaluation for diagnosis was not considered. So the frequency of associated cerebrovascular risk factors such as diabetes is lower in early onset AD. So people who are no, or boxing or various other types of head injuries also can go into that. Patients with early onset AD will typically perform better in which of the following cognitive functions compared with similarly impaired patients with late onset Alzheimer's disease? Is it attention, executive function, ideomotor praxis, semantic memory, visual spatial skills? So the executive function is frontal lobe oriented. You do test by trail test, trail A, trail B, and semantic memory of facts, ideomotor praxis, visual spatial skills. Yeah, that's interesting. So this is which one you are saying, visual spatial skills, right? This is semantic memory. That's the important. And semantic memory is a type of memory which is located in the anterior temporal lobe. Patients with early onset AD will more often present phenotypes characterized by impairment of attention, language, executive function, ideomotor praxis, or rather than prominent amnestic disorder of late onset AD. In aggregate, performance better on memory recognition scores and semantic memory. So the semantic memory is related to facts. It can be sequential. If you ask the individual to say in sequence January, February, March, April, he has to be able to follow that sequence, or he has to, his memories are already stored about the facts of the first president of India and all. So those are the things which are affected. The other memory is episodic memory, episodic memory and semantic memory, or the two memory systems which we'll discuss in subsequent classes. Which are the following the most common phenotypic variant of early onset AD? A. Caliclia variant, corticobasal, frontal executive, logopenic variant of primary progressive aphasia, posterior cortical atrophy, which is the most common phenotypic variant. And that's very interesting. Now when the patient presents to you, then you will know what is the variant. And yeah, this is, you are saying frontal executive variant, and somebody said D, logopenic variant, and unbanded variants E, that's posterior cortical atrophy. That's correct. So the posterior cortical atrophy or logopenic variant, which is these are the mostly it is the logopenic, and the common phenotypic variant of early onset AD is logopenic variant, and primary progressive aphasia has got three: logopenic, agrammatic, and semantic variant. The primary progressive aphasia is totally given to frontotemporal dementia. That is semantic variant. The other agrammatic and this one. This form of dementia presents with progressive aphasia and relatively spared memory and other cognitive domains. The pathology here is characterized by focal Alzheimer's degenerative changes in the dominant temporoparietal language areas, which you can see on the PET scan, especially the superior and mid-temporal gyrus and the angular gyrus, as well as the mid-frontal cortex. And this area is the posterior heteromodal association cortex. And so that's the area in the logopenic variant is the most common. Which are the following is the hallmark finding of the logopenic variant primary progressive aphasia? Is it agraphia, decreased comprehension for words but not complex sentences, disproportionately decreased sentence repetition, impaired motor articulation, intact digit span? Digit span is working memory. Agraphia is posterior parietal lobe on the left side. Decreased comprehension for words but not complex sentences, and disproportionately decreased sentence repetition. This is a logopenic variant. What is the most the hallmark finding of when you want to remember the diagnostic criteria, you have to know. Yeah, somebody is telling that. Yes. D, impaired motor articulation. It is disproportionately, yes, disproportionately, right. Decreased sentence repetition is the correct answer. So, disproportionate decreased sentence repetition is the hallmark of logopenic variant primary progressive aphasia. It's difficulty with repetition of sentences out of proportion to the other impairments. Comprehension is typically decreased for long sentences but not for single words. The motor articulation is generally preserved. Other evidence of decreased phonological store, such as a decreased digit or word span, is generally present. Agraphia is not a component of this variant. So, when in the working memory, you have a phonological loop are also a visuospatial sketch pad. So these buffers will help in formulating the memories which are in the recent memory zone, and they will be subsequently consolidated. So this is the problem here. Which of the following is the typical initial presentation of posterior cortical atrophy? Now, logopenic variant primary progressive aphasia, posterior cortical atrophy variant of AD. What is the typical initial presentation? Anterograde memory impairment, poor judgment and insight, socially inappropriate behavior, speech impairment without aphasia, visuospatial deficits. Yes, that's it. Postocortical, I think, easy. That's why people are answering. It's a visuospatial defect, and that's the most common presentation of posterior. It's very interesting to know how these patients present. Visuospatial defects are the earliest symptoms of post-cortical atrophy may be a vague, non-specific anxiety and sense that something is wrong. The more concrete problems that bring the individual to medical attention typically center on higher order visuospatial and perceptual deficits such as dyslexia, visual agnosia, optic ataxia, and spatial disorientation. In contrast to typical AD, anterograde memory is relatively preserved at onset. In contrast to FTD, personality and behavior are generally unaffected, and insight is also preserved. So the main posterior cortical atrophy problem is pertaining to the only visuospatial dysfunction, which is characteristic of that. We'll learn more about this. Impairment of which of the following cognitive tests is most likely to be seen in patients with early to mid-stage posterior cortical atrophy? What is the test that gets? No, you can easily guess this test. Is it clock drawing, orientation, recall, repetition, verbal IQ? Which test gets important? Yes, right. That's nice. And we have nights. Yeah, that's very nice. Clock drawing is the most important test here that will give the answer. So the preferred response is clock drawing. The screening cognitive tests in patients with PCA typically reveal severe deficiencies in performance IQ, and tests of construction with relative preservation of orientation, recall, repetition, and verbal IQ. The patients usually have difficulties in parietal and occipital tasks such as calculation, spelling, reading, writing, copying complex figures, and clock drawing, describing complex pictures. So that's a good answer. Which clock drawing is a very important test. Everybody should be able to do. Which of the following patterns of amyloid deposition typifies posterior cortical atrophy? Is it global cortical deposition, marked deposition striate cortex, lateral geniculate nucleus, inferior pulvinar, no appreciable deposition, predominant neostriatal deposition, striking deposition in parietal and occipital cortex? So where do you get amyloid deposition in this? The one answer is there already. Oh, lovely. That's first A is correct, not E, Anup. Not E. It's not E. Though it appears the one thing catch point is on all the variants, it's a global cortical deposition. All the symptoms are posterior cortical atrophy related, occipital lobe related, strikingly focal. But amyloid binding is as determined by amyloid positron emission tomography. A PET scan is typically global. It is indistinguishable from that of patients with more typical AD syndromes. Tau PET scanning, on the other hand, shows striking posterior cortical deposition of tau pathology. So tau is posterior cortical deposition, whereas the amyloid is strikingly the global presentation. So that's a understanding which you have to have for this disease. So another case. Now this case will be very interesting. 65-old right-handed lady. She had since for 2 years difficulty with managing stairs. Stair. Since 1 year, trouble driving in the night and sticking to the lane driving. No, she couldn't stick. 6 months prior, ophthalmologist review and found no abnormality, but is recommended a change in the lenses. She presented with difficulty in reading, in that unable to follow lines while reading. What is the case? What do you give the diagnosis? Right. Yeah, Danish, that's correct. That's correct. So it's a, you can see the posterior cortical atrophy here, and we should know what are these are the scans, PET scans, and neuroimaging and PET, and how many ways in which posterior cortical atrophy presents. It's very important and interesting to note also. We'll study after this case. 71-year-old right-handed woman. Since last 4 months, there is difficulty in identifying words or numbers. Last 1 month, she requires magnifying glass to read. She underwent an extensive evaluation with an ophthalmologist, and MRI evaluation was found to be normal. Right now, she presents with, reads a letter by letter basis and then puts the letters together to create the word. So this is also a presentation of, again, same posterior cortical atrophy. So that's how the presentation differs. The ventral posterior cortical atrophy, the abnormal scan, PCR due to AD, treatment with acetylcholine inverts or memantine, and you have to discuss about the driving with them, and you have to take them to the low vision clinic for adaptive strategies. But this will be the PET scan findings. So this disorder, posterior cortical atrophy, presents with predominantly higher functional abnormalities that appear to originate almost exclusively from the posterior association cortex. Posterior association cortex is a descriptive term. Posterior cortical atrophy is suggested by identify the disorder until more definitive causative data become available. So there are autopsy studies which have shown other pathologies also, PCA AD, PCA DLB, PCA CBD, corticobasal degeneration. So 7 out of 9 had AD, 2 out of 7 has DLB, and 2 out of 9 had DBD. So in the collocrine cortex, in the visual association areas are two. One is a dorsal stream, the other one is a ventral stream. The dorsal stream follows the upper pathway, the posterior parietal cortex. You can see it goes to the prefrontal cortex, prefrontal eye fields, premotor cortex, where how pathway for visuospatial attention and visually guided actions. This is important. And the medial parieto-medial temporal stream, that is the ventral stream. It is going the parahippocampal cortex, and this is reaching the fusiform gyrus. So this is a what pathway, and this is a where pathway. So this is problem here. The ventral stream, what pathway for object identification or face identification. This intactness of these networks are important. The ventral pathways and intactness of the dorsal pathways are for the where function. So let us read about the posterior cortical atrophy, repeated visits to ophthalmologist, the changes in glasses prescription without benefit, surgeries the attempting to correct actually are unsuccessful. There is difficulty with reading, and in the vast majority that's a major problem. Multiple car accidents or fines, difficulty reaching for objects, the cups, etc. Dressing apraxias, intact insight. They know that they have a problem, but that's how they present. And see the visual field testing, discrepancy between reading short words to blocks of text as they get lost moving word to word or line to line. So they get lost, and you can see right parietal dysfunction, difficulties in dot counting, line bisection, and clock drawing. The difficulty seeing more than one object at a time in a scene, You can see that's the scene which you can show them, and they have to count the objects which are there in this complex diagram. Inability to interpret the entirety of a visual scene, and can see the tree but not the forest. That's the agnosia part. So this is a visual field testing that is characteristic. So optic ataxia and oculomotor apraxia, these are the two things. The Bellonit syndrome, simultanagnosia, these are the characteristically the same posterior cortical atrophy. Ask the patient to concentrate on examiner's nose, instruct to grab examiner's hand in the patient's peripheral vision. The patient can see the hand and may copy hand movements, but he cannot locate the examiner's hand in the space. That is optic ataxia. The oculomotor apraxia, there is an inability to voluntarily initiate a movement that can be initiated by other means. And like you ask the individual to slowly turn from left to the right, his head, the eyes remain onto the left side for a long time. Almost it takes, after the head turn to the right, 3 seconds for the eyes to turn to the right. That is oculomotor apraxia. And apperceptive agnosia, you can see the diagram here. You can read the E N K, but these people with apperceptive agnosia, they cannot make sense of degraded letters or objects and recognize the same letters in completed form. But if you give them in this picture, they will not be able to identify them. That is called apperceptive agnosia. So the neuroradiology, amyloid deposition in posterior cortical atrophy area and other variants is like typical area. As I said earlier, the tau is posterior, but the amyloid is universally present. The atrophies can be on the MRI scan, and T1, you can see the posterior part is mostly affected. The PC amyloid and tau PET, you can see this we have already discussed. These are the signals. The tau PET signal reflects and mirrors clinical symptoms. I mean, that is the symptoms which are pertaining to vision are coinciding with the tau deposition. But amyloid deposition is seen all over the brain. So there are characteristics now. The gradual progression, insidious onset, permanent early disturbance of visual and posterior cognitive functions. So at least three of the following must be present as early or presenting features, and that is space perception deficit, simultanagnosia in 82%, object perception deficit, constructional dyspraxia, environmental agnosia, oculomotor apraxia, dressing apraxia, optic ataxia. These are the important things which are highlighted here in the darkness. And simultanagnosia is very important. You should do this test in all the cases of dementia. Alexia, right-left disorientation, acalaglia, limb apraxia, apperceptive prosopagnosia, agraphia, homonymous visual field defects, and finger agnosia. So at least three of the following must be present as early or presenting features for a diagnosis of posterior cortical atrophy. The treatment, discuss driving with PCA patients is important. Consultations with the low vision clinic for adaptive strategies. The some home safety tips and recommendations you have to give for the PCA people: simplify the environment, remove the clutter, increase the contrast, label doors, mark burners and stove dials with contrasting color to make them easy to identify. Use brightly colored contrasting dishes and ensure they are all one solid color. Use a phone with a large print. PCA due to AD, treatment with acetylcholinesterase inhibitors or memantine is also recommended. Now next case, a 70-year-old person, since 3 years he developed difficulty with verbal expression. Since last 2 years his problem increased and would pronounce words incorrectly. Pun for spun. The last 1 year he has more pronounced problems with naming. So what do you think? This is the logopenic primary progressive aphasia. There is an impaired phonological loop. There is a type of verbal working memory. Then I said working memory, which is in the precentral region. Yeah, that's it. Let me see, what is it? Semantic dementia. Oh, semantic dementia is a part of frontotemporal dementia. It's not a part of a variant of atypical Alzheimer's disease, right? So semantic dementia, I'll show you later. It's impaired phonological loop, type of verbal working memory. Region holds memory traces for brief periods only, maintains online incoming verbal information. It's like a classic conduction aphasia. So logopenic primary progressive aphasia. That's the diagnosis here in this case. And the history is word finding difficulty and conversational lapses for which the syndrome is named. Word retrieval pauses in conversation. Phonological speech sound errors can be detected. There is a dyslexia is more common among patients with this type of PPA. Disproportionate difficulty in repeating hard phrases and whatever hard phrases, sentences and versus single words. There is a difficulty in repeating them. Signifies an impaired or verbal working memory. I said working memory, which has got a limit of 7 to 9 items at one time you can hold to on your phonological loop and do the work and forget about it. Similarly, you have a visual sketch pad for working, no buffer is there. So here there is a impairment of that phonological loop or working memory, and how both of the following core features must be present to diagnose the logopenic one. There should be impaired single word retrieval in spontaneous speech. Speech fluency is interrupted by word finding pauses and confrontational naming. The impaired repetition of sentences and phrases. At least three of the following should be there. There should be phonological errors in speech and naming, spared single word comprehension, object knowledge, spared motor speech, no distortions, absence of frank agrammatism. But only thing is they cannot repeat sentences. What imaging supports we have? And we'll have imaging must show predominant left posterior perisylvian or parietal atrophy, hypermetabolism on MRI or PET. Because the location for working memory is prefrontal region, where there are the memories: immediate memory, working memory, recent memory, remote memory, and procedural memory. Of all these, the immediate memory is around the primary sensory areas, where the working memory is the perisylvian prefrontal region. The recent memory is hippocampal and pappus circuit. The remote memory is a vast association cortex, and procedural memory is cerebellum and basal ganglia. So you see that semantic PPA, both of the following core features must be present: impaired confrontational naming, impaired single word comprehension. At least three of the following should be present: impaired object knowledge, particularly for low frequency or low familiarity terms, surface dyslexia or dysgraphia, spared repetition, spared speech production, grammar and motor speech. These are all part of the frontotemporal dementia. Here, agrammatic PPA, agrammatism in language production, halting speech with inconsistent speech sound errors, apraxia of speech, impaired comprehension of syntactically complex sentences, spared object knowledge, spared single word comprehension. But complex sentences are difficult in agrammatic PPA. Logopenic, both of the following core features must be present. What are they? Impaired single word retrieval, spontaneous speech. When they are saying that they are not able to talk, there will be pauses. Impaired repetition of sentences and phrases, and speech errors, phonological errors in spontaneous speech and naming, spared single word comprehension, object knowledge, spared motor speech, and absence of frank grammatism. So this is a localization of executive dysfunction, dorsolateral. This is a calculation, comprehension, sentence repetition, very important on the dominant hemisphere. The naming is because of the arcuate fasciculus, which connects the Wernicke area with the Broca's area. And you see the dressing, spatial awareness, neglect, praxis, gestment, balance, and visual. These are the posterior aspect. You see all these localizations, and the you can see the logopenic PPA. That is the parietal region. You can see the posterior aspect, the FDG PET pictures, and you can see the tau PET in the down picture. This one, this is the MRI, which is showing the posterior cortical atrophy. So logopenic has got parietal lobe involvement on the dominant hemisphere. So driving safety, work arrangements, and finances are important aspects which we have to address. The speech and language therapy in PPA has an important role in providing communication aids and strategies. So the speech therapist will come into play. Adapting technologies such as smartphones, communication strategies incorporating pictures can allow continuation of daily activities. Low threshold for trying a cholinesterase inhibitor in patients with logopenic PPS, since Alzheimer's pathology is likely, though any benefit is usually modest. As you say that acetylcholine is the main problem in 82% cases, that nucleus basalis of Maynard has connections all over the brain and it secretes acetylcholine. Case 4, 52-year-old lady. For 1 year, she develops difficulties in cooking. Last 6 months, she started having problems at workplace. Disinhibited behavior set in over last 3 months. Memory is intact. In summary, and the neuropsychology, I'll show what is the neuropsychology, but what is the guesswork of this case? What do you think she is having? What variant of Alzheimer's disease? Alzheimer's disease is a essay question. It's typical and atypical both can be asked. Here, these got developed difficulties in cooking. Last 6 months, she started having problems at workplace, disinhibited behavior over the last 3 months. That means she's not able to plan. The cooking involves planning. Planning means executive control function is affected here. She has problems at workplace because she's not able to plan her day. That's nice. And somebody has answered this. Yeah, that's good. Frontal variant, early onset, excellent onset, excellent. Good. So this is an important entity which shows here learning and memory are minimal, but executive functions are mostly affected. Visuospatial function not that much affected, language is not that much affected, but executive functions, which are the purview of the frontal lobes, especially the dorsolateral frontal lobe. The frontal lobe functions can be divided into dorsolateral, frontal, and medial or anterior cingulate functions. And amyloid PET 2 and 3 is the amyloid PET, which is showing, and tau PET. These are the abnormalities. Though it is showing abnormalities all over, the function is not that much affected. And dysexecutive AD, you can see the temporal sequencing errors and impaired visual processing. So he has to draw this diagram, and he is not able to do this by looking at and drawing. This is not able to do. And so this executive AD, this is the PET scan of that lady. You see the abnormalities are more visible in the frontal lobes. So they treat symptoms such as depression and irritability with antidepressants. The neuronal loss and density of neurofibrillary tangles in the nucleus basalis of Maynard was greatest in hippocampal sparing AD, which is called HPSP-AD. There is a hippocampal sparing AD because hippocampus is not involved, memory is not involved here. This is mostly dysexecutive. Yeah, yeah, that's it. I've told you this. So how to clinically differentiate dysexecutive memory? Memory is this is a very difficult question, but this mostly executive control function testing by trial A and trial B tests, which may help us, and clock drawing also maybe. But memory is it's also affected here, but not that much. So it's a difficult behavioral problems. It's very difficult unless you have a FDG PET, which shows the amyloid deposition, not like a tau deposition. Frontotemporal dementia is a tauopathy, so it's a bit difficult to differentiate and disexecute it. I agree with you. So the case 5, a 60-year-old right-handed lady, a lawyer by profession, presented with difficulty in handwriting and spelling, making letter errors such as substituting J for G over 3 years. She had trouble producing a number while in court over 1 year. She relied on Alexa or Siri to help her with spelling over the 6 months. Last 3 months, her memory is intact, but she developed word finding difficulties. And her score, she has got acalculia. The Kochman score is 30 by 38. Finger agnosia, dysgraphia with spelling errors, no prosopagnosia or simultanagnosia. She had no surface dyslexia. She had very mild anomia. Normal motor speech, mild anomia. Most striking is agraphia, characterized by spelling difficulty. She is not having significant difficulties with reading. So this is a type of case which will present, and the amyloid PET is shown like this. This is the FDG PET. So this is again a phenotype which is very confusing, but we should know the frontal functions, poorly organizational strategies, a dorsolateral problem solving, planning, shifting, maintaining sets, verbal working memory, and reduced verbal fluency. All these are dorsolateral uh, frontal lobe problems. The problems which are anti-cingulate include apathy, little display of emotions, decreased motivated behavior and creative thoughts, failure of response initiation, suppression, poor response inhibition, lack of concern of personal hygiene, appearing unkempt. These are all the anti-cingulate or the medial frontal problems. The orbitofrontal are usually they are tactless, they are obsessive compulsive disorder, decreased empathy, socially inappropriate behavior, and this inappropriate jocular effect, emotional lability, poor judgment, distractibility, increased sweats. In addition to that, there is the frontal lobe has got utilization behavior also, and that's also very characteristic. So last case, I think 58-year-old individual who developed difficulties in depth perception and stopped driving since last 3 years. He stopped recognizing his own son-in-law since 2 years. For 1 year, the left side does not do what he tells. Last 3 months, he was unable to wave with left hand or use brush with left hand. On presentation, he feels that the left hand does not seem to belong to him and moves on its own. What is this? What case is this? So, what is this phenomena you are seeing here? Unable to wave, yeah. Um, that is alien limb phenomena, and possibly that is you are correct, and it's but you know this is the case an example of overlapping phenotypes. When we did the FDG PET is suggestive of something different, which is a amyloid PET is positive, whereas you know that that's a tau pathology, which we should encounter there in the see it's a cortical basal degeneration, but what we saw is an amyloid PET. So all variants have AD pathology, plaques and tangles. So you can have frontal variant, logopenic progressive aphasia, posterior cortical atrophy, this amnestic variant. AD can present locally with bulk, majority of the pathology and the area affected dictate the clinical presentation of the variant. And we have seen that posterior cortical atrophy has got various visual phenomena. So the clinical presentation determines whether amnestic presentation, non-amnestic presentation. So this more than 65 years amnestic presentation, late onset AD. The non-amnestic we have frontal presentations, executive dysfunction and behavioral problems, language and visuospatial problems, and these are the non-amnestic presentations. So 25% of AD cases are atypical, hippocampal sparing ones. What are the characteristics? They are younger age at onset, shorter disease duration, faster decline in MMSE. 5% of Alzheimer's disease occurs under the age of 65. The diagnosis is typically delayed, more likely to be attributed to psychological factors. Major disruptions they undergo in job performance and for families. So whenever a patient comes, we'll have to do all those tests which I showed. So the logopenic variant, in summary, is an early, predominant, progressive impairment of single word retrieval and in a repetition of sentences. The posterior variant of AD or PCA, occipitotemporal variant, defined by the presence of an early predominant progressive impairment of visuoperceptive function or visual identification of objects, symbols, words, or faces. A biparietal variant defined by the presence of early predominant progressive difficulty with the visuospatial function, which has got features of Gerstmann syndrome, Bellnitz syndrome, limb apraxia. The frontal variant, early predominant progressive behavioral changes, executive dysfunction, and cognitive testing. So these are the things. The atypical AD treatment is often this is a hippocampal sparing one. Delayed diagnosis common. Common variants we have already said PCA, logopenic, and dysexecutive. Non-pharmacological treatments are targeted to this syndrome. These patients lose the ability to work at an early age. They require age appropriate support, speech therapy for logopenic, low vision clinic for PCA, occupational therapy for apraxia. So it's a very interesting to understand this pathology, and the posterior heteromodal association area, which is there around the angular gyrus, which gets a feed from the visual area, from the somatosensory area, also from the auditory area, is very important on the left side. Disturbance in the networks in that area are very disturbing to the individual. So I think lastly, amnesic versus non-amnestic presentations of AD, if we want to compare, age of onset is more than 65 years in the late onset or amnestic variety. Non-amnestic frontal variant, they tend to be early less than 65, and there are three types: frontal, language, and visuospatial. The presenting symptom is anterograde memory loss, and that is the key feature of Alzheimer's disease, is episodic memory impairment. If you remember one thing, episodic memory impairment is characteristic of Alzheimer's disease, and if you say semantic memory impairment is more towards frontotemporal dementia. Frontal variant has got executive dysfunction, behavioral change, apathy more than disinhibition, language problems, anomia with preserved semantic knowledge, and visuospatial simultagnosia. The gender difference is also seen in men are more involved in frontal and language variants, the women are more affected in the visuospatial and amnestic variants. So that's a very important aspect. So the memory is a very interesting thing which gets affected in Alzheimer's disease. And how do you assess the episodic memory? How do you assess episodic memory? Anybody can answer? How do you assess episodic memory? How do you take history for episodic memory? Somebody can answer this. How do you take history for episodic memory? Anyone can answer? You are a mental time traveler. You are thinking that what happened last week, where did you go? You are trying to tell, okay, what happened last time. So that means it should be, yes, time locked. Uh, Recent visits and item memory. It's not item memory is a fact. So that is semantic. Semantic memories are hard facts. Time frame, when, who. Who is again a fact. But if it is time frame, it becomes episodic memory. And how do you assess anterograde learning? What are the tests you use for anterograde learning? Because that's a bedside test. Anterograde learning, how do you assess? Because that is a not digit span. Digit span is used for attention. How do you assess? Anybody can answer. Anterograde learning. How do you assess? Because that is a key feature of Alzheimer's disease. Words recall. What is the test called? Race auditory verbal learning test. How we do is that 15 words are given to the patient. First presentation, you give one word a second, ask him to recall how many he can recall. Like that, same list, same order, you repeat 4 times. And every time you ask him to repeat and mention the score he scored. He should progressively improve by the time fourth thing came. There is other fifth list, a separate list is given, again recall is given. So that's how anterograde learning is. No, how do you test semantic memory? How to test semantic memory? How do you, that's okay, come down to how do you test? Okay, that's it. How do you test? On bedside, color of sky, fast test, fund of knowledge, okay, PM of India, excellent. So these are the, that's a type of category. Sequencing, sequencing. There is a category semantic memory. There is a sequential semantic memory. And where is it localized semantic memory? Semantic memory, localization in brain, not lateral temporal, anterior temporal, anterior temporal, and sequential is by asking, yes, by asking what are the months in a year, what are the months, the sequential they should be able to tell, then that is a sequential. Very good. So I think on this, on the occasion of the brain day, we had an excellent revision of the brain function. I thank you all, and if there are any questions, you can ask me. If there are no questions, we'll keep on conducting these classes, and I want to prepare for the next year DNB exam. This year it's already over, so I request what we should carry to DNB practical exam for dementia case. Can we carry GB Pant dementia formats along? Uh, I think you should remember two or three tests for each lobe. First important, attention. For attention, you have to test first by digit span, digits forward and backward. If attention is impaired, other tests are not going to be performed because they cannot do. So first you learn to do attention tests. After that, for each, for verbal memory, auditory verbal learning test, you see, you mocha chart, you remember, you see, it is a rough idea they have to do. The verbal memory and the visual memory. The visual memory raise auditory, oh no, sorry, Benton's visual test, visual memory test. You draw a circle, you draw a rectangle, you draw a triangle and show them immediately and remove from their vision and ask them to redraw them. That is a visual memory. That is on the right cerebral hemisphere. The right and left cerebral hemisphere, you have nothing. You carry your own what you think that's important. So how do you want to test recent memory, remote memory? Because it's very difficult to go for a format in an exam. MMSC is a must. So you do MMSC, and after MMSC, first you do attention, then MMSC, then you do lobe testing with two or three tests in each lobe. So for the temporal lobe, visual memory, verbal memory is very, very important, and episodic memory by testing the questionnaire, which you know. About the construction, clock immediately should draw. Clock drawing is very important. If you are able to make him draw a clock, and you have the executive control function with you, and he is able to put the limbs in a correct place. 10-20 means he should be able to put 10-20. That means his executive control function is good. So you remember that you should draw a clock. There is no format. Ames dementia format is too long. G1 is too long. That is only for evaluation when you are in OPD. In exam, it's not practical. In exam, you should have a short test. There is a 5-minute Alzheimer's disease scale and a mocha domains. And you should remember the domains which you're going to test. You have to test for dementia, executive control function, apraxia, aphasia, agnosia. So these domains you have to remember. You have to remember these domains in your mind to tell, okay, I'm going to test these domains and see if there is any problem. If you think Alzheimer's disease is the main problem, you have to demonstrate anterograde learning defect and episodic memory defect. If you think your problem is frontotemporal dementia, then you have to go for semantic memory testing. Okay, I think you people understood this. Okay then, see you all for we'll conduct more classes on Friday evenings, and will be exam preparation for DNB neurology. It will be done. Thank you. Okay then, good night.